ใช้ได้แล้วใช่ไหม Okay, good morning, everyone. First, I have to thank the committee to let me join such a wonderful conference. So my topic is about the technique in liver parenchymal transection during the laparoscopic hepatectomy. So the principle of the laparoscopic liver parenchymal transection is 5 things. You have to make the proper port and trocar position to make a good exposure. Another one is adequate inflow control to see the demarcation line and let your operative feel dry. And then you make the mediculous parenchymal transection to see the pedicle and hepatic vein identification, and then you make a effective hemostasis. Then another one is the correct transection pain. So you have to see the landmark inside the intrahepatic landmark. Like a hepatic vein guide parenchymal transection is a good technique. And the last one is the oncological resection margin. So so maybe ICG and intraoperative ultrasound combine to get the better outcome. Unlike the open technique, the laparoscopic approach is you will see caudal side of the liver, and it's difficult to limited the visualization at the posterior superior part. So the proper port and trocar position is very important. So mostly the patient sitting in the low lithotomy position, and operative table you have to test before you perform the operation. This is my port and trocar for the right left hepatectomy, central hepatectomy, or segment 4, or left lateral sectionectomy that can, or we can do with this port position. So you can see the caudal view, like I did this case of the right hepatectomy. After you clamp the right pedicle, you can see the demarcation line, and then you approach from the caudal side. Okay, you can see the middle hepatic vein as the landmark. And for the difficult position like a posterior sectionectomy or anatomical segment 7, segment 6, I prefer the left jackknife or left semi-prone position. Is my port position. So the first I do the first camera 5 mm trocar as above the 2 finger bed from the ASIS. It's my first port, and then when you see everything clearly, you make the another port. It's view when you see the when you do the lap segment 7 resection, and the video show the lap right posterior sectionectomy. So in this position, you can see the right hepatic vein better than the low lithotomy position.
โอ้โหเตรียมไว้เลยเหรอ
The right hepatic vein view in front of you alongside with the camera line, and your left hand port really easy to perform the parenchymal
ใช่แล้วเดี๋ยวเราจะทำอินทราออกอัลตราซาวด์แล้วก็
left jackknife
สเต็ปแรก
position.
เดี๋ยวเราทำอินทราออกอัลตราซาวด์แล้วก็
So the good info control
injection
in my hospital we mostly perform extracorporeal finger maneuver. It's very quick, fast, and effective. And intracorporeal finger maneuver we use only for the lap width resection, because all the case is a short operative time case or superficial weight resection. And for the Gestonian pedicle control, you can see the ischemic demarcation line clearly. For the intrafascial approach, you have to cut the liver first, and then you control the G7 or
ที่อยู่
G8.
ในนั้นก้อนใหญ่
I usually use this technique for do the lap subsegmentectomy of segment 7, segment 8. The another one of the principle is the medicular dissection. So they have the superficial and deep parenchymal transection. For the superficial parenchymal transection, Kaneko that proposed this picture, he said there's no no major vessel or bile duct up to 2 centimeters deep. So you can in my technique I use the ultrasonic device like harmonic or sonic excision to perform superficial parenchymal transection. In this video clip, I use the harmonic scalpel. So I activate the active blade, gentle insert into the liver parenchymal side, and then continuous grabs the device and continue to activate it. So you can see it's no bleeding. Then you continue to the along the demarcation line that at the group of between right and middle hepatic vein. But in this technique, be careful for the dorsal side of the liver because the middle hepatic vein so close. So if you activate the active blade, maybe you may be injury to the middle hepatic vein. So be careful in the dorsal side of the liver. And for the deep parenchymal transection, you have to see the clear pedicle and hepatic vein identification by the QSA or clutch cam technique, by the ligature or harmonic. And then if you see it clearly, you make an effective hemostasis by sealing device or clip or the hemarog. So the QSA move, the one who's proposed this technique is Professor Honda. So the QSA is a highly effective tool for the liver parenchymal transection. It's used ultrasonic energy to fragment the parenchymal tissue. So the QSA have the 3 functions. By Professor Honda, he proposed that the first one is fracturing, suckling, and stanching. Fracturing and suckling. So the QSA use the ultrasonic vibration cause the hepatocyte which have a high water content and low fibrous content to fragment to be the aspirate by the device. Structure with more fibrous tissue like a wall of blood vessel and bile duct are more resistant to this vibration and thus relatively spare. So they seem to be selective tissue selection by spare the vessel and duct. And the function is the third function is stanching. He described that when is bleeding occur, he used the shaft of the QSA compress and activate by the soft coagulation mode to seal the blood vessel. But the soft coagulation mode, you have to only one company, Herbe, and only one company, Herbe, can combine with the QSA. So if you want to use the soft coagulation mode, you have to ask the engineer technique to combine it for you. And the movement of the QSA, he proposes a showering. Showering is move the QSA forward and fracture the liver during aspiration the liver cell out from the parenchyma for the pedicle. And then if you see the pedicle or hepatic vein, you do the boring technique. So boring technique remove the parenchyma alongside the hepatic pedicle and vein, and then you can make the hemostasis. The last movement is the back scoring. Back scoring technique is move the QSA from the trunk to the peripheral alongside with the main trunk of the hepatic vein. So when you move the QSA like this, they may have the injury that called the pull-out injury. The pull-out injury is a small bleeding, and then they can spontaneously stop by itself by the pneumoperitoneum or low CVP. The pull-out injury can stop spontaneously. But if you do the QSA for the peripheral to the root, that may create the split injury. That's much bleeding and difficult to control. So this video clip show to do the back scoring technique. In this case, I do the right hepatic vein guided parenchymal transection in the right posterior sectionectomy. So you can see I activate the QSA tip to the from the peripheral from the trunk to the peripheral along with the right hepatic vein. When you see the branch, you do the boring technique, and then you measure the size of the hepatic vein. So it's I think it's allow 3 millimeters. So I use the clip and then seal it with the bipolar device. So the QSA movement technique, they have to you have to do the continuously, precisely, and at one movement. Do not by pushing, don't lash and clip practicing. Another technique is a clump clutching technique by like an open technique. So you can use the bipolar device such as a ligature or the harmonic to perform to fracturing the liver parenchyma. But they will be a little bit dirty, so you have ask the assistant for suction. I usually use the clutch clamp technique after I secure the major vessel already, like a last procedure. So it's very quick. So they're not important structure like this. So you, in this case, I use the ligature to clutch and seal with this zone. It's no bleeding. And another concept is you have to do the correct transection pain for the rookie, for the new one to do the laparoscopic approach. Sometimes you got into the liver parenchyma and you don't know which way to go. So because while doing the parenchymal transection, they have no direction sign. So you have to see the intrahepatic landmark. This is proposed by Dr. Ravisak, 3-point landmark. So you have to clamp the info control to see the demarcation line or use the anatomical landmark, superficial anatomical landmark. First, then when you do the deep parenchymal transection, you have to see the intrahepatic landmark, like middle hepatic vein, right hepatic vein. Then, after you perform the right hepatic vein guided parenchymal transection, you keep the pain to the finishing point, like a portal pedicle or IVC. So the transection pain should be aligned with the optical trocar in accordance with the triangular rule. So you have to have a good traction and counter traction. The operative table can rotating. You can move the camera. You can move the right hand port for the better exposure of the transection pain. For the hepatic vein guided transection, I usually do for the anatomical hepatectomy because for the deep seat or invisible lesion, by identifying allow the tumor as a landmark and exposing them on the cutting plane. It's very useful when the surgeon cannot secure the surgical margin by the palpation. So they have three fissure vein, like in the liver, right portal fissure, main portal fissure, and left portal fissure. It's called the intersegmental plane or intersectional plane. This area is no bleeding, like Professor said. It's a watershed area. He showed in his video clip. It's no bleeding, no cautery. If you go to the correct plane. It's a many approach for the hepatic vein guide. So another speaker will talk about this. So I will show the middle hepatic vein guide transection. It's very important when you do the major hepatectomy, like right hepatectomy or left hepatectomy. So when you find the small vein, you trace the vein to the main trunk, not cut it for the first time. Then you follow the main trunk to as far as possible by the good traction, caudal traction. Then you see the in this case I do the left hepatectomy, so you see the V4, and then I move QSA as a back scoring technique. And after it's so much tension, you clip and seal it by bipolar device. As the paper show, when you perform the middle hepatic vein guide, you should go into the anterior or posterior apex because there no branch around this area. So middle hepatic vein guide, hepatic dissection is a landmark for anatomical right and left hepatectomy. Avoid damage to the intrahepatic portal vesicle and preserve venous drainage and functional liver tissue. For the right hepatic vein guided approach, right hepatic vein was dry in the right portal fissure. So you have to see it when you do the central hepatectomy, right posterior sectionectomy, or anatomical segment 7. Because the right portal fissure is no external anatomical landmark. You can see only the ischemic demarcation line, so you have to ultrasound guide and see it in the hepatic approach. So be careful if the patient have the inferior right hepatic vein, the main right hepatic vein may be not fully exposed. And then if you see the pedicle or vein clearly, you should use the clip or hemorrhoid for secure it. So if the small vessel and distal pedicle not large to 2 millimeter, you can seal it by the bipolar device. But for the medium size of the hepatic vein, maybe you can use the sealing device, or you can clip and seal it by the bipolar device. It's called the double secure technique. And for the gestational pedicle, I recommended you to use clip and seal because it prevents the bile leak after the operation. So for the last one is the oncological resection margin. So in my hospital, I usually perform combined laparoscopic ultrasound with the ICG camera. And I use ICG like a ICG tumor imaging technique. Now I don't use the negative stain because it will interfere the tumor identification. So it's very useful when the tumor sit in the deep area to avoid our resection. So I will show the video. It's a lab segment 8 resection. The HCC is on the group between middle and right hepatic vein. You can see it's fully you can see the tumor stain the ICG already. And so you have to clear the the vein V8 and the anterior fissure vein form the tumor. So I continuously clip and seal, and then you can see the anterior fissure vein and middle hepatic vein. So just keep dissection, and you can see the exposure not good. So I approach from the caudal side, and then gain more the exposure. You can seal. You can clip the anterior fissure vein safely and seal it. Okay. So the ICG tumor imaging technique was helped for gain more the resection margin. So if you believe in the interlenic approach and you select the case as this case is a round and small HCC and it's no invasion in the hepatic vein, you can detach it from the trunk of the middle hepatic vein. Okay. Okay, I will skip this. Okay, for the conclusion, the principle of the liver parenchymal transection, you have to make a good info control, adequate exposure, medical dissection, and have the good correct transection pain and oncological transection. Thank you for your attention.